Good morning and welcome to Parasitology and Mycology. My name is Dustin Scott Brewster, and this is part 2 of the malaria and other blood and tissue protozoa. The stages of malaria include the pre-patent period, which is the stage from infection until first discovery on the blood film. The incubation period is the time from infection until the first symptoms appear. These symptoms would include the prodromal stage, which are the more benign symptoms of malaria, such as headache, malaise, anorexia, and nausea. The prodromal stage would precede the paroxysm, and paroxysm are the more severe malaria-associated symptoms, such as profuse sweating, fever, and chills. A paroxysm is an asexual round of reproduction that begins when the merozoites infect the red blood cells. They develop into trophozoites, mature into schizonts with their internal merozoites. They reach the capacity of the red blood cell. They rupture and release those merozoites, kicking off a new round of infection from the time the merozoite infects the red blood cell to the time the new merozoites lyse the red blood cell and leave to start a new round of infection. That is one paroxysm. Blackwater fever is a complication of Plasmodium falciparum from the very malignant type of progression that Plasmodium falciparum has. A lot of merozoites are being produced in the developing schizont, so more red blood cells are lysed, causing more severe anemia, and this mass hemolysis and lysing of red blood cells can cause hematuria, that is blackwater fever. There's some natural genetic resistance that can happen, and this is typically found in regions endemic to malaria. The first is sickle cell trait, which is a natural genetic resistance to malaria due to a mutation on the hemoglobin gene that produces an S hemoglobin. Malaria isn't capable of utilizing that S hemoglobin in the growth and development stage of the erythrocytic cycle of infection, thus allowing a bit of resistance. It does not provide immunity. You are still capable of being infected by malaria and the exo and erythrocytic cycles, but the parasite isn't capable of using that defective hemoglobin. Duffy factor, however, does offer some immunity, to malaria, specifically Plasmodium vivax, and this is provided by an individual's lack of Duffy factor. That is, the Duffy factor is an antigen on red blood cells that the merozoite uses as a portal of entry to infect red blood cells. If you simply don't have the Duffy factor antigen on your red blood cells, then you are immune to Plasmodium vivax. Treatment for malaria involves prophylaxis, which is the administration of drugs prior to entering a region endemic to malaria and Plasmodium species. And then there are therapeutic elements that would be administered after infection has been diagnosed and the species has been identified. There are some certain species of Plasmodium that are resistant to therapeutic drugs. This would include Plasmodium falciparum as well as Plasmodium vivax, specifically in the Papua New Guinea region. There are two ways that malaria infection can stir back up, and that is through relapsing and recrudescence. The difference between relapsing and recrudescence is that relapsing involves dormant stages of the Plasmodium reinfecting the host months or even years after treatment. And this is due to the hypnozoites developing during the exoerythrocytic cycle of infection, and they stay in a dormant stage they call hypnozoites and are released months or years after the original infection. The only two species of Plasmodium that are capable of relapsing are Plasmodium vivax and Plasmodium ovale. Recrudescence, however, is simply the incomplete therapy of drugs after infection has occurred, and you simply don't take all of the anti-malaria drugs, and you knock the infection down, but you don't knock it out, and thus the Plasmodium will gain back control, the infection will stir back up, and that is recrudescence. All species of Plasmodium are capable of recrudescence. Only Plasmodium vivax and ovale are capable of relapsing. Prevention, obviously detect and prevent infected people from spreading it to other people by not getting bit and having the mosquito take in the macro and micro gametocytes, and also mosquito control using malathion and things like that. Immunity can occur from infections. Incomplete immunity, you're not going to be completely immune, but often people get infected a second time, but their body reacts more appropriately, and they can often go months or even years without realizing that they actually have malaria again. Collection of the malaria specimen is best using a finger stick. You would clean the site, you would lance the finger, and you would apply the drop of blood directly to the slide without trying to make contact, not making contact directly with the slide to the finger. You want the blood to drop on the slide. And a venous stick is also an appropriate specimen type. You'd want to collect that in a red top, and you would want to make the smear, the thin and thick blood smears, as soon as possible after collection using the red top. The time to collect is best midway between fever peaks, between these paroxysms. Multiple stages can be present in infection, but usually there's one dominant stage, and there can be multiple Plasmodium infections, but there is, again, typically one dominant form over the other Plasmodium. This would be differentiated using a unique characteristic specific to the sub-infection, in the Plasmodium species that isn't the dominant infection. The blood smears, you want to make at least 2 of each type of blood smear, a thin blood smear and a thick blood smear. So 2 thin blood smears and 2 thick blood smears. A thin blood smear uses intact red blood cells, and it's simply made by a simple wedge method that you would do in a standard hematology lab making a CBC differential. A thick blood smear, however, lyses the red blood cells, so you're targeting specifically the organism itself. So it's a little more sensitive. You've lysed the red blood cells, you've removed the cellular debris from those red blood cells, and you're focusing specifically on the organism itself. The appearance of a thin blood film, the red blood cells, what you're going to be looking for is the size of the infected red blood cell. Is it normal relative to the other red blood cells in the image, or is it slightly enlarged like you would see in certain species of Plasmodium? Also, is stippling present in the infected red blood cell? The cellular components of malaria parasite, the cytoplasm is usually light blue, the chromatin reddish to purple, red staining, and the pigment of the developing trophozoa actually does not stain. This is a product of digestion from hemoglobin to hematin, and the color can vary a little bit, but usually bouncing between brown and black. Features of the thin blood film. Appearance of the parasite, what are we looking for? We're looking for the outline of the developing trophozoite. Is it smooth, or is it rounded, or is it irregular? And the density of the cytoplasm, is it compact or diffuse? Amounts of color and pigment, black or brown, heavy or light. This would help differentiate macro and micro gametocytes. Stages present, there's usually one dominant stage, but others can be present. One thing definitely to take note of is the number of developing merozoites in the skyzone. This is a species-specific average, so the number of developing merozoites is definitely worth taking note of. Features seen in the thick blood film. So again, the stages present, there could be multiple stages present, but there's typically one dominant. This would be the ring stage of the trophozoite, the more mature developing trophozoite, or the schizont with its internal merozoites, and then gametocytes can also be present. Outline of the developing trophozoite, is it smooth and round or is it irregular? This could help distinguish between different species. The density of the cytoplasm, is it dense or diffuse or compact? Again, what we were talking about a second ago between macro and micro gametocytes. Amount of color, amount and color of pigment, and again, the number of merozoites is definitely something to take note of. That would be a diagnostic characteristic of the specific Plasmodium species. So average those numbers out for different species, have different average numbers of merozoites in the developing schizont. The shape of the gametocyte is characteristic in certain species of Plasmodium. Plasmodium ovale, Malaria, and vivax can't really be distinguished, but Plasmodium falciparum, however, has a very characteristic banana-shaped gametocyte. This is going to conclude part 2 of the malaria and other blood and tissue protozoa. We're going to pick this back up with part 3.